Okay, so today is June 29th. It's Thursday, right? Thursday, we're having an in-service on falls in skilled nursing and expectations from our CNA, what we expect our CNA to do once you have a fall. Here at Seacrest, a couple of the implementation that we have or policies that we have to prevent a fall is we have a census that tells you who is at risk for falls, okay? And again, this in-service is not, it's not about preventative, it's more or less what you need to do after the fall. But we're just gonna hit off on a couple things that we do in terms of prevention and in terms of falls. But when you see a red dot like that, it means that resident doesn't have the capacity mentally to prevent themselves from falling, and safety awareness is poor, right? So that kind of gives you an idea that, hey, I shouldn't leave this patient in the bathroom if they have to use the bathroom, right? Sometimes we forget though, like the patient appears to be A&O times 2. You guys know orientation yet? A&O times 4 means when you start working in and out of skilled nursing, the nurses might say to you, this patient is A&O times 4. That means that patient is fully oriented, okay? That means they're aware of their time, their surrounding, people and situation. So those 4 things tells you that you're not confused, okay? Now, if you orient times 3, sometimes the nurse says she's oriented times 3. She doesn't know where she's really at. She knows everything else, but she's oriented times 3. If you have a patient that's oriented times 3 and lower, or 3, 2, and 1, then you probably have a patient that might have these, fall issues, okay? So, but technically, most of the ones that are a fall risk are going to be the ones that are weak, that are, still think that they can do things independently, but are starting to lose like some of their orientation. Okay, so and you can get orientation really quickly by talking to your resident. Like for example, what's your name, man? Yanel comes in, she's brand new. You got a new admit, right? And you're like, man, okay, I need to figure out whether this patient's A&O times 4, 1, 2, or 3, right? And the nurse is not here, or the nurse is too busy, whatever the case may be. You're not getting the report that you want to get, and you need to provide care for this patient. When you come in, you introduce yourself. My name is Yanelli. You knock first. Hi, Mr. Whoever, Mr. Brown or whatever. My name is Yanelli. I start asking questions in regards to the orientation. Ask them where they're at. Do you know where you're at? They're the new patient, right? Do you know where you're at, Mr. Brown? If he says that I'm in Virginia, then you know he's not oriented to place. And then just ask him as you're talking to him, oh, that's great, just go along with it, right? Just be like, hey, how about the time, Mr. Brown? And do you know what the date is today? What time it is? And if he says, it's January, it's if the blinds are closed and he thinks it's AM or PM, you go down the list, and then eventually you'll figure out whether he's A&O times 4 just by making regular conversation. Now, is he oriented to person? Like you can start asking, who's the president, right? Like if they tell you, Bush or whatever, right? Way back in the 80s or whatever, right? The old Bush, right? Then, they're not oriented to person, obviously, right? But if they're oriented to a lot of times though, they know where they're at, but they may not know the time, okay? And it's likely because they had an infection or they've been in the hospital for too long and they don't really know where they're at. In that case, they might still be a little groggy from the medication. So you want to pay attention to that also as a fall risk in patient. So that's orientation. I'm kind of getting out of our main topic here, but and also I wanted to show you guys what the nurses are actually doing when it comes to falls, because falls on this guidelines right here, falls are the leading cause of morbidity and mortality. Not only that, it's the most costly type of event that occurs in skilled nursing, because it's liability too, right? The surveyors can come in and say, okay, is this related? Was this a preventative type of fall? And if it was preventative, did the facility provide enough intervention to prevent the fall? And that's always been our big thing. When Nancy was a DON, this was something that we wanted to work on all the time, right? And if you had implementation or intervention that you already have in place, but the patient keeps falling down, you have to keep adding stuff on there to make sure that the next time they don't fall, okay? And you do get caught up sometimes. No matter what kind of intervention you got in there, the patient keeps falling down, okay? a lot of times what's going to get us most in trouble if the patient is, if the fall is related to like environmental factors, that can get you in trouble. For example, you have a patient who's oriented times 4, right? And she's walking around and she's like, hey, I fell down because there's no lights. or I fell down because somebody, the CNA left, stuff on the floor. That can get us in trouble. Those are just preventative stuff that could have been prevented by us by keeping the room nice and clean and clear, right? Also, if the patient is oriented and they wanna do things on their own, and you just kind of document that they want to be independent, and that typically kind of gets you out of the hook if the patient does fall, because you've already documented they want to be independent. But residents that are confused are the ones that are very difficult, because you gotta have actions and implementation to prevent that fall. Regardless, you already know that patient is probably gonna fall unless you have a private caregiver, but you just gotta have some form of intervention there for that resident. Okay, so let's go back to Yenny real quick. She's doing her rounds, right? Like an hour later or whatever after lunch, she's doing her rounds and she sees her resident on the floor. What's the most important thing you should be thinking about in terms of that resident's safety, and your next action would be? What do you need to be thinking about? But what would you be doing first?
I would check on the patient.
Check on the patient, okay.
Mm-hmm.
And would you move the patient around,
No,
pick him up to get him comfortable?
I would stay with the patient, call out for help, or call for a nurse.
Okay, call for a nurse, yeah. Why would you want to call a nurse, and why would you not touch or move the patient?
Because I don't know why they fell. Like maybe they tripped on something, maybe they're injured, and like I don't want to worsen it.
Yeah, exactly, right? So in terms of a patient who might have a fracture, let's say cervical or whatever, and you start moving this patient around because you want, because the patient, hey, get me up, hurry up, I'm fine, I didn't hit anything, I just kind of slid down. But in reality, they might have a cervical fracture, right? And so moving her around might make it worse. But you gotta put that on the nurse's hand, okay? Have the nurses come in, they'll do the range of motion, and then you'll get enough help to get that resident up safely. But if you try to move this patient around, and I'm not saying it happened here in our facility, but sometimes what happens is that when the patient falls down and they're like, I didn't hit my head, just get me up, it's fine. And it doesn't get reported, you get them up, oh, okay, it's hush hush, we're not gonna report it or whatever, it's gonna be fine, because there's no bruising. The problem with that is that if the patient starts having pain later, and the bruising starts coming out a couple hours later, and it gets the CNA and the nurses in trouble, okay? Not too long ago, we lost a nurse who didn't report a fall, right? And the patient this was a couple years ago, but the patient fell down and was not reported, was not documented. The patient started having pain. We did an X-ray. There was a fracture, and then the CNA said, "Oh yeah, she fell down. Yeah, he fell down. I don't know why it wasn't documented." So that nurse got in trouble, right? And probably lost her license. But I remember that nurse leaving, and then she was fighting for her license, basically. It could happen to anybody. It could happen to nurses, to CNAs as well. But you just want to be careful. Things that happen, it's better to report no matter how bad the situation is. Hopefully we have the right approach. We have the right intervention. Your managers and everyone around that facility that's in admin should try to protect you in terms of your employment as well, right? So long as everybody's doing the right thing. In any case, so falls are the leading cause of morbidity and mortality. A lot of these patients already have osteoporosis, so if they fall down, they might break a bone, and then they'll get an infection, or a lot of times happen is that they're not able to walk around as much. They get constipated, right? They're laying down in bed more now because they have pain. They get pneumonia. So it's not the actual fall that's gonna get them. It's usually their immobility, okay? Because they're already not eating and drinking as much. And now we're gonna put this, fracture in place, and now you're having more pain, and they're gonna be depressed. And it's just the outcome of the fall that's really significant for this patient, right? And so it's very costly, and it's very detrimental to the facility, because a lot of times happen too is that we don't do the right documentation, and when we get these follow through from surveyors, they start asking you questions: why you didn't do this? Why didn't you complete that? So it's important to kind of go over some of those policies when you become a nurse or when you start working for a facility, what they expect. All right, so now we came in, and Yenny came in, and she waiting for the nurse. What's the next step? What do you expect after that? What would you be expecting from the nurse? She's already done her assessment, and there's no fracture. What do we expect when moving forward?
For the nurse to do vitals?
Yeah, the nurse is gonna do vitals, right? And so we also we expect to do vitals, but we expect the nurse to basically assess the patient, like from head to toe, right? If you have a nurse who says he's fine, and then you don't see the nurse looking at like the back and the hip and for any kind of bruising, she's probably not doing it right? Because you want to look for injury, and so in order for you to do that properly or adequately, is you're gonna have to assess the skin. Okay. Now it may not be bruised up now, but within an hour, 2 hours, 3 hours later, the bruise might come through. Okay. So that's why it's important to really monitor this patient. Okay, now we got our, let's just say that it's unwitnessed, right? It's an unwitnessed fall. We don't know whether the patient hit their head or not. Since you guys are new, you're likely not gonna know what the next step is, but if you, this paper right here is called a neurological assessment. As a CNA, expect to do vitals every 15 minutes for 1 hour. The first hour, let's just say the patient fell at 12, you're gonna do vitals every 15 minutes until 1 o'clock, okay? The next hour after that, you can do 30-minute vital. And then after that is every hour, and then it's every shift. And we do this, every shift type of vitals, monitor for 72 hours, okay? The 72-hour monitoring for patients, significant, side effects from the fall, right? What do you think some of the symptoms are from a head injury?
Concussion.
What is it?
Concussion.
Concussion, right? But what are some of the symptoms?
Symptoms.
Dizziness, right?
Throwing up.
Heart rate, throwing up, right?
Confusion.
Increase, like change in mentation, right? Any of those symptoms, right? Change in vision, right? If you notice that within that 72-hour period when you're monitoring this patient, you gotta tell your nurse, like, hey, you know what? I think we're having a neurological issue here, and the nurses are doing other, checking, like they're looking at the pupils, right? Orientation. They're also looking at this, but they're so busy that sometimes, hey, you know what? Maybe the CNA is the one that's gonna be catching this. Because they fly through their med pass and assessment pretty quickly. They should be spending, an X amount of time on their assessment, but they're not because they have 20 patients. So they might miss it. And so you're the extra eye and you're catching this patient. You know this patient's orientation. You know how they usually act. And now they're, hey, I got a headache or I got blurry vision, or they're just more agitated, So, and then maybe you notice that he vomited and there's no interest in eating, right? Some seizure maybe, right? So you want to rush this patient to the ER, basically get him checked out. So it's 72 hours of monitoring. Let's say you come in the next day and you notice that in the 72-hour chart that patient is not on there. Okay, it's likely that we missed the monitoring, and maybe, just maybe, that the nurse didn't document it. Okay, so but just tell your supervisor. And like I said, sometimes it gets so hectic that we forget to chart things, but these are important things. Like I said, falls is one of those things where it's probably one of the most significant events that could happen in skilled nursing, because there's a follow through with CDPH, the California Department of Health. Okay, when we have a fall, and it's the only event where we fill out SO3, right? SOC 431, right? SOC 431 is related to abuse. And why would you think that if somebody had fallen down, that we need to fill out the SOC 341 is related to abuse?
Because they fell here.
Might be deliberate.
Yeah, it could be neglect, right? It could literally be neglect. Okay, so if somebody fell down, and this form is filled out when there is an allegations of abuse or abuse has occurred. But if you had a fall, these nurses are going to fill this out if the patient is sent out to the hospital or if they fractured something. And that's because an investigation has been done whether the facility was doing the job or not. Why the fall could have been the fact that, hey, you guys never checked on this resident for hours. I mean, he's sitting in his bed and wants to use the bathroom. You guys never went over there to check on him to use the bathroom. And now he fell down, and it's neglect, right? So that's why we fill out this form. So expect that to, basically, if there's a fall, expect that there's going to be a follow-up, especially if it's a significant fall that's resulted in a major injury, like a fracture or something like that. And even if there's no fracture, a lot of times these surveyors will come in and follow through in the facility, okay? And so it's very nerve-wracking in the position where the DV1 is sitting, because not only we do care about the resident, we want to make sure that resident is fine, but she can't control the nurses, their documentation. And a lot of times what gets us in trouble is the documentation. And a lot of times the skills have been done, and we've done what we need to do with monitoring, but we just don't get this documentation in place. We don't get it completed. And so the CNA too, you have an obligation to do a statement. right? Whether you saw the patient or not falling down, if you were taking care of that patient, let's, for example, you took a break at 12 o'clock and you came back, it's 12:30, and the nurse said, hey, your patient fell down. Well, your statement should say, before I took a break at 11:45, I saw this patient in bed laying down asleep. Okay? Now at 12:10, right after I took a break, he's on the floor now. That's a gap of what? 25 minutes. That's not bad. I mean, yeah, the patient was probably taking a nap or whatever, and there's a gap of, maybe 20 minutes that you didn't see him, but at least it's not a 2-hour gap, right? It should, like, the nurse shouldn't say, oh, when was the last time, like, if the survey comes in and asks, when was the last time you saw this patient? Oh, I don't know. I did a med pass at 10 o'clock, it's now 12 o'clock, that's the last time I saw him. And then I don't know when the CNA saw it. That shouldn't be the case. You took a break. Yes, at 11:45 I saw this patient laying in bed, and 12:10 now she's on the floor. So there's a 10-minute gap, and that should save you, right? Your statement should say that, like, hey, I did this, I did that, and this is the last time I saw my patient. I'm coming back to my break, and now, actually the fall was noted at 12:10. So, if you do everything correctly, and just be real with all your documentation, it should save you. Even though it sounds weird, sometimes the fall sounds really bad and it looks like we're gonna get in trouble. But if you did everything correctly and you did everything right, we get away with it, okay? And I'm not saying, hey, let's have all the falls in the world because we're gonna get away with it by just doing right documentation. That's also not right, because the more falls you have, the more you're gonna be on the microscope, okay? So just be aware of that. The other thing is just notifying the family member, and it's not up to you guys to notify the family member. Obviously, the doctor's gonna be notified, but family members are sometimes gonna ask you what happened, so be prepared to kind of know these events that has occurred. What else do we need to add there, Nancy? Anything else? What do we expect our CNAs to
Look
do?
around the room. If you are the first one finding the patient on the floor, note how they're lying or sitting, because sometimes people will move around. So for example, you walk in the room, you see the patient slid down, their back is against the bed, their butt is on the floor. That's important, okay? Because if our patients can't tell us if they hit their head, sometimes we can look at their positioning, or you may get in the room and the patient fell on one side and they're like, oh, I'm gonna roll over. Make sure you note where they were initially, okay? That's what we need you to do. Look around the room. Do you see any spills on the floor? The nurse should be doing this too, but one of your duties, along with that of the nurse, is to make sure if the patient is getting up, they have non-skid socks on. And we have tons of them in our closet, okay? People getting up with bare feet or slippers that don't have a grip on the bottom, they're the ones that are gonna slide. Okay, or if you notice, you walk by and you see somebody trying to get out of bed, you've got to alert everybody else that this person is a fall risk. We might not know it in the beginning, but we see them, as they get better, they're starting to get up, they're starting to move around by themselves. So let the nurses know, okay? By the same token, if you see somebody who was alert prior and now maybe we don't know yet they have an infection or something, but they're acting confused, then you need to alert people to the fact that, hey, they might be a fall risk now. Okay? And as John said, people with dementia are usually at higher risk for falls because they're going to forget they can't walk. They're going to forget they're not supposed to get out of bed.
I'm gonna let you guys in on a little secret here too, right? The nurses are usually wanting to know, did the patient hit their head or not, right? And what is the significant part of that in terms of, like, whether the patient hit their head or not? Concussion, right? So if the patient, if let's just say the patient, you saw the fall and the patient didn't hit their head, we don't really need to do 15-minute vital, because we don't need to do all these neuro and all these other stuff, because we know he didn't hit his head, right? We do vitals every shift for the next 72 hours and then monitor for any ill effect from the fall. But there's no extensive work there in terms of neuro, because we didn't hit our head. Once you say, hey, I saw him hit his head, we're gonna do all this, okay? We're gonna check the pupils, we're gonna monitor, we're gonna take vitals every 15 minutes for the first hour. We're gonna do all this extra work, right? The nurse is gonna be checking the pupils, every shift or whatnot. We're doing all that, so that way we're sure. Now, what if the patient fell down and is unwitnessed? We didn't know whether they hit their head. Do you think we're gonna be doing this?
Yes.
Yes. If you say that it's an unwitnessed fall, we're gonna do the neuro. So it just gives you an inside view, basically, why we're doing the things that we do. Because when you come in as a CNA, you're gonna be like, why are we doing all this crap? Like, oh, excuse me, why are we doing all this? It seems like a lot of work. We just do the vitals, right? I'm gonna cut that out too in my video. Yeah, that would be the reason why.
John,
we're
and the
doing all
other
that.
thing you can do is if you're the first one in the room, ask the patient what happened. See if they can tell you what happened.
Yeah, based on your knowledge and orientation, what do you think the patient is available? You got to take into consideration,
Right.
Orientation, right?
Yeah.
And so if the patient was AO times 4, absolutely, you take take all of their words for the word by word. Just say, but if you have the orientation times 2 or 3 resident, you might
Yeah.
wanna, I don't know, if that's,
Sometimes you can't always
Yeah.
find out.
because that could be because a lot of times, and also even oriented resident, they're gonna be like, no, I didn't hit my head, man, come on, man, because they don't want to do all the extra work as well, right? They already know because they've been there too. They're like, I remember the last time I did this, so they're gonna be like, no, I never hit my head, man, get out of here. I didn't even fall down, I just slid down. So remember the meaning of fall. If somebody is falling down or about to fall, or you guided them on the floor, it's a fall, right? If they're touching the ground, whether you was a guided fall or not, it was a fall, right? And it's a witness fall. You don't have to do the neuro, but you're gonna do a fall event. Okay? So and somebody's gonna say, hey, you know what? I just guided them on the floor. It doesn't. That's considered a fall. You guide them on the floor. You do an event. Because then you're trying to figure out whether that patient, how did he fall? Is this gonna happen again? Right? Investigation starts to kick in. Does this patient need therapy? Is the patient has a change of condition? Maybe they have an infection. Maybe it's keeping them weak. So there is an investigation that does happen after the fall, where the nurse will come in, or the DO1 will come in and try to figure out what is the cause of the fall, and we add intervention after that. So, but if you're a CNA and you're like, hey, I feel like this is what we need to do, remember adding, if you don't already have, if you notice that the patient his bed is always high, and they're just easily can get up and they're confused, you might say, and the nurses or your or your managers are not implementing low bed, you might want to say, hey, why don't you keep the bed low, right? But in order for that to happen, the people that's overlooking your fall has to implement that, because they implement it to the nurses implement it to the CNA. But if none of the nurses are talking about it, then you're likely it's not going to happen. So say, hey, why don't you keep the bed low, right? So if the patient is orient transformed, like, absolutely not, I don't want to keep my bed low, then you don't keep it low. But if a patient is, orient times 2 and has poor safety awareness, absolutely you can implement that as a nursing intervention. And then, so that patient will have a hard time getting up, yes, but you're supposed to be checking on this patient frequently. So if they're trying to get up, you should be like, hey, do you want to use the bathroom? What is it? Are you having pain? But then that prevents them from falling down, right? Bed alarm also, right, is another thing. But it would benefit you as a team. It would benefit your run to tell your nurses, hey, why don't we do this? Why don't we do that? Don't just stay quiet. If you have something in your mind that say, hey, you know what? I think this would work good for this resident. Okay. But there is a lot of videos in there as well. I'm sure your managers that you work for, when you work for skilled nursing, they already know all the implementation. But sometimes they get so busy, they may not be really familiar with your resident, and they might not implement the things that should be implemented. So, it would help that if you guys can say, hey, this is probably good for this resident. The glaring on the floor sometimes can cause a fall. So maybe clean your glasses, and also the footwear, the proper footwear that Nancy talked about.
Call light.
Yeah. And taking to the bathroom more frequently, keeping the bed low, and having the bed alarm. All important aspect of preventing a fall. These things right here, that we do this. Making sure that everybody's aware who's a high risk for fall. Okay. All right. What else can we add, Nancy? Is that it?
I don't know, do you guys have any questions?
Any questions on what you need to be doing? So you guys are comfortable. You walk into a room and somebody falls down, right? You already know you're gonna be calling the nurse first, right? You expect to do vital signs every 15 minutes if it's an unwitnessed fall, if there's a head injury, right? You expect to do a head to toe type of assessment, in that patient to make sure that there's no bruising, no broken limb. What are some of the things that tell you that the patient has a broken hip or has dislocated hip? Screaming. Pain is one of them, right? But there's sometimes they may not be in pain, okay? But if they're laying there and you're sitting down and the nurse is trying to get this patient out and you clearly see the legs rotated or short, there's a socket that came out, right? A lot of times it's twisted like this and it's clearly shorter than the other, right? It's significant. And I've been to so many falls while working for hospice. The most of these patients are taking like pain meds, or maybe even they're not. They just have a high level of pain, and they're not going to tell you they're in pain, but you clearly see it. You clearly see the dislocation. You're going to tell your nurse, hey, hold on 1 second. Before you get him up, look at this leg, man. He's short. It's inverted this way. You might want to do x-ray, you know what I mean? And then that's going to tell the nurse to basically lift this resident in a different manner rather than just pulling him up, with one assist, right? So those are some of the things you might want to consider in terms of, when you're looking at a patient and assessing the patient, right? So also, when you come in the next day, you want to make sure that you're monitoring this patient for ill effect, right? So as a CNA.
The other thing is, if the nurse decides the person has to go out, we might tell you, please make sure the person is clean and presentable before we send them to the emergency room. We don't like to send our residents looking messy to the emergency room. So for any time we send somebody to the hospital here, we always make sure that if they're incontinent, they have a clean brief on, have a clean gown on. You wouldn't want your family member sent out to the emergency room looking a mess or being wet and smelling and things like that. And we may ask you to help gather things up to go to the hospital if they're going to the hospital.
Yeah, perfect. Any questions?
When a resident falls, we call out for the nurse, but we don't report it. It's just the nurse's job to report it. So when the resident fall down, initially what you need to do is make sure that the patient is not bleeding everywhere, that they can breathe normally. When you see that there's no extensive bleeding, they're breathing okay, just call the nurse. Hey, you know what? Somebody fell down here. Okay. So, but your duty at that moment is to be right there with the nurse, right? And then when she does her assessment, do the vitals or check the patient. But the reporting comes and documentation comes in the. You don't really have a documentation at this point. Even afterwards, you don't really document. You're only documenting bowel movement, vital signs, all of that. But there's no way for you to even say this patient fell down at this whatever, and we call a doctor and we did this, all that. There's no way for you to do that because there's no platform for you to chart. It's all nursing. It's all the LVNs and the RNs job. But if you notice that the following day that you're not taking vitals related to a fall, it was likely missed. Either they missed the whole documentation and reporting, or they just missed the vitals. In either case, that's got to be added, because the vitals has to be taken at least every shift after the 24-hour period, right? So, but in terms of you physically reporting it, there's really no way for you to do it unless you think the fall was related to an abuse case where the nurse pushed the resident or somebody pushed the resident. Then you can report it anonymously or to your supervisor or to ombudsman, this phone number here. You can report it. There was an abuse that taking place. Yes, in that situation, yes. Okay.
But in terms of just like a fall is not related to abuse, no, there's no way for you to really report anything or document anything, But if a family member comes to you and asks you about a fall, you can pretty much say, hey, you know what, this is what happened based on my end, but you can certainly talk to the nurses, and see what they got, So you just tell them that, what you thought happened and what you saw happen, and then an ad saying, but go check with the nurses because they have all the information. Okay. But good question. All right, any other question? Any question about the pizza?
Yeah, that was really good.
Was
Are
good.
we gonna get it again?
Yes, hopefully, when Nancy buys them.
Oh, I
don't think
this
we're
time.
going over that.